Well, good afternoon, ladies and gentlemen. It's nice to see that the A team have stayed behind to listen to the final talk of this session. My name is Charles Kingsland. I'm the Professor of Reproductive Medicine at Edge Hill University in Liverpool, and I also am a consultant at IVI UK based in London. I have no commercial interests in Cooper, but the reason I think Cooper Surgical have asked me to speak today is that many years ago I developed an interest in aspects of in vitro fertilization which could optimize outcome, particularly collecting eggs and transferring embryos. And it's kind of serendipitous now that 25 years later there have been such great strides in improvement of outcome from our embryological colleagues that I feel now that the onus is back on us clinicians to deliver the highest quality gamete in the best condition to give to our embryologists so they can make the highest quality embryos that we are then charged with placing back into the uterus as carefully as possible. It still surprises me after all these years that we go through all of these incredible advances with NGS, embryo biopsy, embryoscope, but the final technique is the critical one, and that is putting this tiny little embryo, the size of a sharp end of a pin, into the uterus at the most appropriate time, in the most appropriate position. So what I want to talk about first are methods of oocyte collection. And a lot of these things that I'm going to talk about that I first mentioned when I approached Wallace 25 years ago for them to develop a needle for me that could safely collect eggs, they still pertain today. First of all, obviously, the needle has to be long enough. It has to be sharp enough. But in the early days, in the mid to late 1980s, we used to have reusable needles, and many times the needle that we were given had been through an autoclave maybe 4 or 5 times and was quite blunt, and you had to put a lot of pressure into to pierce not only the vaginal mucosa but the ovary, causing significant trauma and maybe damage to the ovary. So it has to be exceedingly sharp. It has to be firm, because there's no point in getting the needle and thrusting it into the vaginal mucosa and it bends or distorts or doesn't even pierce the ovary. And again, many years ago, I'm sure some of the older members, clinicians in the audience will remember trying to put needles into ovaries and the ovary rotating round as you tried to pierce the capsule of the ovary. Obviously, it has to be highly visible so that you can easily see it on ultrasound, and more importantly, you can easily see it when it disappears, so that you can stop what you're doing and refocus, relocate the needle and start again. But something, going back to my MD thesis, which I found extremely important, it had to be wide enough. We used to use 14 gauge needles in the mid to late 1980s with a flushing arm and a aspiration bore that were very wide. We didn't have the benefits of anesthesia or intravenous sedation, so the majority of patients were sedated with Valium or Pethidine. Now, as you know, Pethidine is not the best painkiller. It was described to me by anaesthetists as that if you take a big slug of Pethidine and then you put your hand on a hot stove, you'll say, well, I know my hand's burning and I know it hurts really, really a lot, but who gives a fig anyway? So a lot of patients didn't have the benefit from the modern anaesthetic agents. So what I wanted to do was to create a needle that was narrow enough to be as painless as possible, but had an internal diameter that was as wide as possible. And my supervisor for my MD, Professor Robert Edwards, he always told me that the oocyte cumulus complex could be 1 millimetre in diameter. So really you had to aspire to getting a needle that had an internal diameter of 1 millimetre. And as you know, if you talk about laminar flow down a river that flows is more turbulent near the banks. It's more laminar near the middle. So what you don't want is a turbulent flow that might damage the oocyte as you aspirate it out of the needle, out of the ovary. And similarly, you need a pressure that was extensively investigated by Carl Wood in the early 1980s that doesn't exceed 150 micrograms, millimeters of mercury. Because then, if your bore is too narrow or your negative pressure is too high, you're going to stand an increased risk of damaging the oocyte and giving it to the embryologist, who's not going to be very happy with you. So these are the things that I thought were very important. Fortunately, Wallace catheters made an 18-gauge needle, which I still use today. In the NICE guidelines that are published in the United Kingdom every 5 years, we also do not recommend that flushing should be a routine procedure. I know a lot of clinics still offer flushing as a way to optimize the number of eggs that you get. But really nowadays, now that we can control ovarian stimulation and we don't have to go for immature eggs because of the risk of ovulation, we can grow those follicles a little bit larger, not too large, because we don't want the eggs to be post-mature, because our embryology colleagues tell me now, do not give me a post-mature egg because I won't be able to fertilize and biopsy it as well. So we want eggs that are the appropriate maturity, but they're a bit like, I liken them to apples on an apple tree. If you've got a ripe apple, you don't have to spend a lot of time picking it, it'll just drop into your basket. If you have to use force to get your apple, then the likelihood is it's going to be less ripe, it's going to be sour and inedible. And that's the same with oocytes. There's a risk and benefit analysis to be made between the number of times you flush a follicle and the damage you create and the pain you subsequently create in the patient, and whether you just aspirate. Now obviously, if you've only got a few follicles in a poor prognosis patient, then it's probably in the patient's interest that you do flush. But if that patient had a good response with good follicular growth, with a cohort of good sized follicles that are not too big and not too small, then there is really no evidence to suggest that you should flush that follicle or curette it even. I had the privilege in the very early days of working at Bourne Hall Clinic, which is the oldest IVF unit, and my mentor and PhD advisor was Robert Edwards, and he had a friend called Harry Wallace, and it was Robert Edwards who asked Harry Wallace to design for him a catheter that was atraumatic, that could easily penetrate the cervical canal, that could be loaded with embryos safely and carefully, and those embryos could be delivered into the uterine cavity. And really I see the Wallace catheter, which has changed very little over the years, as being the gold standard. I don't know whether you in the UK, but 2 or 3 years ago there was an advert that was very popular of the Volkswagen, and this guy goes into the Toyota shop or some other car showroom, and the salesman was saying to the would-be buyer of his car, well, look, listen to the doors. These These sound just like a Volkswagen, or listen to that engine. It sounds just like a Volkswagen. And it's a bit like in the UK, if you're a gentleman, you'll know that the gold standard for underpants is Marks and Spencer's. You know, if you go to Marks and Spencer's, you buy underpants that are better than Marks and Spencer's, or not as good as Marks and Spencer's. Maybe the ladies are the same. But that's how I see the Wallace catheter. It's the gold standard, it still is. And it's the catheter that we still use, and that Robert Edwards designed. And if you were able to have had the experience of working with Robert Edwards, working in the laboratory, and me, the junior research fellow, working in the oocyte collection room, you'd realise the enthusiasm, the clarity, and the carefulness with which he used his embryological techniques to load catheters, to load the Wallace catheter, to the point where, for me personally, I would be afraid to change. But there again, I'm getting old, and I don't change many things anyway. So, what are the key points for embryo transfer? If you'd have asked me 10 years ago, I would have not said that ultrasound was important. And I would have said that the important thing is experience. And we had this technique that we called the blind approach, or the feel approach. That if you're eating your dinner, you would look at your dinner and cut it up with your knife and fork. You wouldn't look at a screen. But the meta-analyses and the randomized controlled trials have suggested now there's a strong evidence base that you can get better outcomes by utilising ultrasound to transfer embryos. Not only from your own clinical expertise or your clinical practice, but it's also far more reassuring for the patient to actually see where you put your embryos. And now it's a routine practice for us to demonstrate the embryo as it's inserted into the uterine cavity to the patient. And I'm not so sure that in the future we'll have to have evidence that we have actually put that embryo that's been so carefully created by our embryologists. We will need to prove that we've actually put it where we said we'd put it. We need to have a soft catheter. The uterine cavity, the endocervical canal is liable to trauma. We don't want to see blood on the catheter if we can possibly avoid it, because we know that will reduce our pregnancy rates, so it needs to be soft. We need to put that embryo into the mid-cavity, so we need to see where it goes. We want to avoid unforeseen problems, so I think it's good practice nowadays that we practice our embryo transfer on our patient before they arrive in the embryo transfer situation. So we have an idea what we're going to encounter. And I know lots of people would dispute that and say, well, if you do a mock embryo transfer in the cycle before, the environment, the circumstances might have changed when it gets to embryo transfer. I find that difficult to understand now, and I think it's vitally important that we have some data to give us the idea whether this is going to be a difficult transfer and an easy one. And if we think it's going to be difficult, let's make it easy. Let's do a hysteroscopy. Let's do a cervical dilatation, so that embryo has the easiest journey back into the uterine cavity as possible. Going back to the late 80s when I worked at Bourne Hall, after embryo transfer, we used to have patients on bed rest for 48 hours. In the basis that I can remember, going around doing ward rounds 24 hours after embryo transfer and just passing the time with small talk, how are you today, and still the same. Any clots in your legs because we've made you lie in bed for 24 hours? No. But I think it's now fairly safe to assume, based on the evidence, there's no real need for bed rest. Socially, I think it's nice for a patient to probably relax and reflect for 15, 20 minutes maybe. But there is no evidence to suggest that once you've done the embryo transfer, any period of bed rest is going to be a benefit. We shouldn't have to give medication. We shouldn't have to do cervical blocks or sedate the patient. There are some that do require a little bit of relaxation, but the vast majority, if they're well prepared and you're well prepared, should have should be fairly straightforward. And finally, and probably most importantly, I think there's no substitution for doing lots. In my previous clinic where I worked for 25 years, we had a cohort of nursing staff that were trained in embryo transfer techniques that did them all. And each one of them were performed over 200 transfers. And that was one of the criteria that we had, that to maintain your expertise, you need to do lots. And I think the days have gone now where Professor so-and-so, who probably does one embryo transfer every 6 weeks, comes in and does an embryo transfer because he's the head of the unit. I think you have to do lots. And it's quite, we have as Steve said in the previous talk, we have a culture of openness and transparency, so we audit our results. And if one of our embryo transfer practitioners' results drop, then we all get around in a huddle to see whether we can learn as to why that has happened and whether we can improve outcomes. And that optimizes. You might say, why did I have the nurses doing it? Well, in our unit, where we were doing up to 3,000 cycles a year, the nurses were always there. The turnover of nurses was much lower than the junior doctors, and nurses tend to follow protocols better than doctors. So they were more liable to follow our standard protocols to optimize our outcomes. I think nowadays with ultrasound technology, it's very difficult to argue against not being able to see where your embryos are being transferred. And now, this was a paper that came out of Los Angeles 2 or 3 years ago that Dr. Gergley coined the phrase maximum implantation potential on 4D ultrasound, where he pinpointed midpoint between the angle between the fallopian tubes and the upper third of the uterus, which is something that we aspire to now. We're looking at developing an evidence base as to whether that is actually of genuine clinical benefit. But I think reasonably that's the best place to put it, and that's where we should aspire to put it, in the upper third, 1 centimetre from the fundus. And something that's really exciting that I hope that we will be able to adopt in the not too distant future, if we can afford it, is the concept of 4D ultrasound guided embryo transfer. I think that's going to be, satisfy our embryological colleagues when they give us these grade 1 blastocysts to put back under 4D ultrasound control, so we can aspire to the golden 70% implantation rate. And that's your needles and catheters, and thank you very much for listening.